Good afternoon, everybody. We're going to get started. Go. Just seeing some people. Perfect. Okay. We're going to get started. My name is Kara Fletcher. I'm the director of the Social Work Research Center, and pleased to welcome you to our first Lunch and Learn of the fall semester of 2025. And we're really excited to have Erin Beckwell, one of our research associates here, presenting on a study. Erin was a co-PI on the study of improving pain in Saskatchewan Study. And this is a solutions-focused storytelling to promote people-centered care, challenging stigma with chronic pain and substance use through graphic medicine. So Erin, I am going to talk less and let you talk more. So I'll turn it over to you briefly. Just two quick things. One is there will be time for questions. So if you have some questions, Erin will facilitate those with you. And if you can keep yourself on mute during this presentation, unless you are asking a question, that would be wonderful. Thank you so much. And I'll turn it over to you, Erin.
Thanks, Kara. I posted in the chat a link to my slides and the stories. There's also, okay, sorry, I'm just making sure I can actually share my slides. Okay, there we go. I think that worked. Yeah, okay, good. So there's also QR code on the front slide if you want to do that instead. But in the folder are my slides as well as the 3 graphic medicine stories that I'll talk about today. So you can see the stories in their entirety. And we will talk about how you might be able to use those stories as we go through the session today. So thanks everyone for joining me. It's been a really interesting journey and a real privilege being involved in this work, and I'll talk quite a bit about my involvement in a moment. But first, I just want to acknowledge I'm coming to you today from Treaty 6 territory and homeland of the Métis people. So I'm based in Saskatoon. This work was conducted in the spirit of truth-telling and reconciliation, highlighting stigma and disparities in access to healthcare services and in care experiences. During our time together and beyond, let us strive to understand and honor the truth and history of this land, build respectful relationships with ancestors of the place, their descendants, and the land itself. So, just a couple pieces before I move forward. Of course, I didn't do this work alone. I was co-PI with Dr. Susan Tupper. I also use this because who doesn't love when you've been turned into a cartoon? And so that was one of the neat parts of doing this work, is getting to see myself animated. But we had support from Saskatchewan Health Authority, of course, the U of R, Saskatchewan Pain, SWRC, who was our funder through the Skipper program, and our Canna Creative, who did amazing work with us on developing the stories and the graphic design. So just a bit of background on the whole study. So I joined the Improving Pain in Saskatchewan team way back in 2019 as a patient partner, actually. I was working out in community then, and Dr. Susan Tupper invited me into a community engagement event to sort of identify what Improving Pain in Saskatchewan could look like as a project. And so out of that came the 4-phased project. We're actually now completed phase 4. The project started with interviewing stakeholders in 3 different communities. We had a group in Regina, a group in Yorkton, and a group here in Saskatoon. And they were interviewing folks to find out about gaps in systems and services and opportunities for pain management, sort of improving that. And so each group in each location made its own decisions about what they wanted to focus on based on what they found for their interviews. And so their interviews in each location were with healthcare providers as well as people living with pain, their caregivers. And so the group in Regina actually focused on pediatric pain. And so they had a pediatric pain conference, an interprofessional conference, and then actually created a storybook for children about experiences of pain. That has now been released. the Yorkton group focused on healthcare providers and how do we better support healthcare providers and educate healthcare providers. They also briefly touched upon the lived experience of healthcare providers with pain, because pain has been shown to be quite prevalent among healthcare providers themselves. And so they focused on that and eventually developed a podcast for their sort of knowledge translation piece. And so the study's third phase, after sort of the co-design of what are the sort of interventions or change strategies that they were going to use, we supported implementation and evaluation of those in each community. And then our final phase was knowledge mobilization. And as I said, there was a podcast, a storybook, a conference, and then in Saskatoon, I'm going to share with you today about our graphic medicine stories, which are, well, I love them because they're creative. They're different, they're fun, even though they're tackling some tough stuff. And so, yeah, here are some of the quotes that we took from phase 1 and 2. Specifically, most of this came from phase 1. But when we were talking with folks about their experiences of pain, people talked about begging for pain management, being treated very poorly, being referred to as a junkie, drug seeking labels, those types of things, particularly in acute care settings, of course. But people felt often like healthcare providers, doctors in this case, wanted them to just kind of go away because they didn't know what to do with them. That sometimes pain is not believed or is fundamentally misunderstood, which often left people saying things like, they thought it was in my head. And, identifying that as an additional pain point is having someone not believe your expression of pain. Labeling, again, based on taking opioids, prescribed or otherwise, right? And then resulting in anxiety when seeking care subsequently. So we had 4 themes that guided our knowledge translation: reduce stigma, facilitate access to support, service, and care, support engagement of people with lived experience, and foster wellness in a broader paradigm than simply pharmaceutical management or acute, even sort of hospitalization, et cetera. And so trying to bring awareness of a broader range of strategies to manage pain. So shifting gears a bit to the graphic medicine stories that we created. So, one of the things that was interesting was looking at the purpose of stories and power of stories, that people remember how stories make them feel. There's often an emotional connection. It can sort of inspire someone to take action, more so than if they only heard facts and figures. And there's been a lot of work done across the country on raising awareness of the prevalence of pain, especially chronic pain, and trying to help people understand. And this is one of the first times, well, it's the first time in Canada that graphic medicine has been used to discuss this particular issue and share the experiences of people with pain. And so we really wanted to sink deep into the idea that humans are actually wired to interact with story and to sort of share with others, and that this is a really interesting sort of avenue to go. And so I love the notion, that we're storytelling organisms. We use narrative structures to organize our thoughts and our world. And so why don't we sort of dive deep into that and see how that can help us communicate some fairly nuanced and complex experiences that people told us about. So I'll tell you a bit about our process and how we got there. So we started out by really trying to wrap our head around stigma and how we were defining that for the purposes of this work. So of course we wanted to recognize that stigma is often multifaceted and layered for people. There are hierarchical and power boundaries based on particular characteristics or attributes of groups: race, age, gender, sexual orientation, substance use, status was one of the pieces we focused on specifically, weight, health status, religion, politics, housing security, employment, etc. And so helping the people we were interviewing and the folks who were involved in our story creating really recognize this layered, nuanced experience of stigma, and then attaching the social process of stereotyping and moral labeling. Sort of how do we sort of harness that, but in a positive way, right? So rather than sort of perpetuating stigma or deepening stigma, how do we actually take this notion that humans like to create stories which become stereotypes, and how do we create different stories? And so we also wanted to highlight dynamics of power, and that, you know, stigma always includes some element of deprivation of power, agency, and belonging. And that when we look at healthcare provider patient interactions or client interactions, you know, there's always that power imbalance that can really fuel stigma or make stigma much more impactful in people's lives, typically negatively. And so we looked at, you know, a sort of tiered approach to stigma, looking at structural types of stigma. And in our interviews in phase one, in the stories that we collected there, you know, we were looking for sort of threads of stories that spoke to societal norms and beliefs, availability of sort of funding for healthcare services and research on these issues, policy that may be stigmatizing, program delivery frameworks that may be stigmatizing or reinforcing or maintaining stigma. And then we looked at interpersonal stigma, which of course in our interviews, people were more inclined to talk about the interpersonal layers because it's more readily visible in our lives. And so talked about unconscious bias, talked about, you know, experiences and delivery of care, lots of sort of thoughts and feelings about their experiences with care providers, and then inclusion of people who access services or people with pain in decision making. Then we also, of course, looked at internalized bias and you know, how that impacts care seeking, how that impacts people's comfort and safety in disclosing all relevant information about their case or their issue of the day, and then social withdrawal and sort of disengagement. And so we decided to take these themes, these ideas, broad ideas, and look at them through a narrative inquiry approach. This is how we began our process of creating the stories. And so we did narrative interviews with 13 people living with pain and who use substances. So there was sort of dual requirement for those folks, and then 5 healthcare providers. Some of those folks were interviewed in phase one. Some of these were new people who had no experience with the project before. So then we undertook a narrative analysis and created composite stories. And so, you know, sort of looking at themes, going through what are the stories, the narratives, the threads in the data, and then how do we dovetail those together into stories that illustrate those themes. And so we then created our stories through an iterative process as a team. It took months. And we used what's called a 3-act framework, and I'll explain that in a minute. But essentially creating, you know, sort of a foundation for a story, a conflict, and a resolution. And so we also wanted to have some type of sort of teachable moments or actions that people could take after engaging with a story. And we went back to the people we had interviewed. We also did a focus group with 7 healthcare educators to talk about what they saw as the teachable moments in the stories we had created. Interestingly, the healthcare educator focus group was, and I'll just say as a researcher, one of the most challenging conversations I've ever had to sit and witness. Some of the things that were said in that conversation really illustrated why we needed to do this. We had one healthcare educator, for example, suggest that maybe people with pain need to be taught how to better engage with their healthcare providers rather than trying to teach healthcare providers to provide better care. and that, sort of wanting to put it back on the people accessing services. And I had to work pretty hard to tell my face in those moments because I was sort of wanting to be like, what? Like, this is our job as healthcare providers, that we have obligations ethically to provide good care, to combat discrimination and stigma, and to expect that we should be teaching patients to be better somehow was very, I was unexpected. It did surprise me, and really gained some interesting conversation among the rest of the team. It actually sparked one of the best conversations because people really responded to that, and were saying, no, like, we need to do better here. And we cannot put the responsibility for good care on patients and how they interact with us. We need to learn how to better engage in that interaction. So yeah, that was quite interesting. And then, of course, our knowledge mobilization, which is publishing our stories. And we have ideas about where we'd like to take those stories now they've been created, but we'll talk about that as we go. So our 3-act framework starts out with introducing our key characters, and a challenge is introduced. So what's the problem? What's the challenge here? And then as we see the characters navigate choices, there's a fork in the road. There's a decision point. And every one of our stories has this sort of moment where key characters make particular choices, and then the outcomes of the choices are realized. And at the end of each of our stories, we have sort of what many call the moral of the story. We called it sort of the what ifs, asking questions like, what will it take to make lasting changes based on this knowledge? So we created 3 stories. And as I said, they're in the link, and I might just paste that again in case folks joining later can't access the one that was in the chat. And so our first story is called Teresa's Story. All of our stories start with, it doesn't have to be this way. That was sort of the overarching theme. And it was actually a quote from one of our research participants, that, it doesn't have to be this way. It could be so much easier, so much better, so much less stigmatizing for people. So Teresa, in her story, she's in the emergency room 3 months after being in a car accident. She's 6 months pregnant, struggling with sleep. She feels pain all over, and her pain is getting worse. And so it's sort of a classic emergency department environment, which of course we know these days is busy, overcapacity, introducing a lot of additional environmental stressors to people, and includes a process of triage where somebody attempts to, in this story, quantify Teresa's pain. And, so she's met with a triage nurse, rate your pain on a scale of 0 to 10. And, for Teresa, her response to that question is, sort of trying to grapple with how her pain is a number, because that doesn't resonate with how she makes sense of her pain, which of course, as for people living with pain, the pain scaling is a common topic that we like to complain about, right? Is how it is, especially ongoing pain or pain that might change. How does it fit? And then are there cultural implications of using pain scales, assuming everyone interprets them the same, et cetera? And so, in our story, Teresa takes a stab at it and goes, 4? Like, I don't know. And I think, that's a very common experience for people with pain, that putting a number on something, while from a healthcare system perspective, might be helpful and important, for people to distill a complex experience of pain down to a number is often incredibly challenging and not really relatable in a lot of contexts. And so in this story, we had a variety of sort of teachable moments or themes that could be picked up and used in as a case study to illustrate different issues like comprehensive pain assessment in emergency departments. But also this story could be used for exploring unconscious bias and, how do we help people recognize what that can mean in practice and how unconscious bias shows up sometimes. This story could be used when we're working with folks learning about pregnancy and sort of prenatal care. How do we manage chronic pain in pregnancy? How do we make the pain scale work for both the provider and the patients? And there are actually variety of projects that have happened around the globe that have attempted to create something better. And yet health systems still tend to lean on the 0 to 10 pain scale in most cases. Providing alternatives for language. So in this case, there's the provider uses should language a lot. You should do this. You shouldn't do that. And this case could be used to explore that language, right? How can we talk about this in other ways that might not come across as judgmental, accusatory, just sort of throwing expectations at Teresa. Teresa's Indigenous. And so one of the elements of the story is that, the care she receives isn't necessarily culturally responsive. And so we envision that this story could also be used to explore what may be some Indigenous wellness resources for chronic pain management, right? Are there more culturally responsive, culturally appropriate tools that could be used in care? And then connecting patients to resources. We had a group of med students who were learning about insurance and all these other topics, and looking at this story in terms of what are resources that we should connect patients to when they've had a motor vehicle collision. And that may include a reassessment later on for ongoing lingering pain. But also other resources in community, making sure people understand those systems, community-based chronic pain resources. And I'll say there are a few in Saskatchewan. There aren't as many as I would like to see. There are certainly big gaps in Saskatchewan, and there are some very dedicated folks working on addressing those. But what we found through our interviews and our conversations with healthcare providers is they generally do not know what's out there. And so people end up not being informed about even the possibility that, say, chronic pain could happen when you've had a car accident. And then do we have resources? And often, especially in acute care, there's minimal knowledge of community-based resources around pain and even psychoeducational resources so people can better understand pain and how it works in the body. Another element of Teresa's story was she had borrowed pain medication from a family member to address her pain before she went to the emergency room. And she, of course, didn't do this, because she had some sinister motivation to, break the law or do anything like that. It was desperation. And her family member was being kind and trying to be compassionate. And so then, in this context of emergency department, how do healthcare providers ask about and navigate the situation of borrowed pain medication without contributing to stigma, stereotyping, judging, because of course there's often a sort of negative reaction to that. Of course, there's risks of that, but typically what we heard from people is when those things had happened, if they chose to disclose it, they were often judged, treated very poorly, and ultimately, in some cases, deterred from seeking additional healthcare services because of that experience. I just see a question in the chat about the resources we have in Saskatchewan. Regina has a community-based chronic pain clinic. The Saskatchewan Health Authority is actually developing a chronic pain pathway that allows people to come in through a variety of primary care connections. So going to a family doctor, for example, not available to everyone, but one avenue that people could connect in with a variety of people across the province. They're looking at using virtual care to expand reach of those resources. There's also the nonprofit SaskPain, which exists to provide education and system navigation, sort of, They're a volunteer-run organization. They have no paid staff, and so it's incredibly challenging for such a small organization to do a lot in terms of one-on-one support, but they provide information about what's available and how to navigate it as best they can. And so they've been a key partner of this work as well. So our next story is Jim and Dr. Houghton. So Jim is an older fella who has been struggling with chronic pain, and his family doctor is Dr. Houghton, and she wants to taper him off his pain medication. And that's sort of the challenge of the story is Jim doesn't want to reduce his medication, and she is really focusing on that. And there's some conflict between them where Jim's just tired and frustrated and feels that one of the only things that has brought him a bit of relief is being taken from him, and that he's not being heard by his doctor in expressing that she seems to have an agenda to taper him off his pain medication. And that is also not an unusual scenario these days. We heard about that from many people that, all of a sudden, and people said it seemed sudden often to them that my doctor has decided that I can't take these medications anymore. And of course, when we look at the broader context of things, yes, there's been a really strong movement towards questioning prescribing practices with especially opioid pain medication. How individual practitioners have responded to that varies greatly. And some, yes, are sort of saying every chronic pain patient I have needs to be tapered off their pain meds, full stop. And that isn't always communicated well. It isn't always actually best care for people. And often the benefits that people get from pain meds the patients we talked to said they feel like they were not acknowledged, right? That it was talked about like these are bad things that need to be taken away because they're causing you harm or could. And patients really struggling with, yes, and they also help me manage my pain. And taking that away seems terrifying, especially when people shared that there was often not non-pharmaceutical pain management strategies explored. It was just take away, and we don't have anything easy to give you. And so a lot of fear, a lot of anxiety. And so Jim's story is about that. And so outside of a hospital setting, it's in community. And so, this story touches on themes of building therapeutic alliances with patients, right? How do you actually have good established rapport to have tough conversations in healthcare settings or in other care providing settings, right? So that if difficult decisions are being made, they're being made in a relationship where someone feels seen and heard, and that there are ways to be collaborative in the approach to care. And so there's also some interesting content in this story about body language and nonverbal cues that Jim doesn't say a lot, but he says a lot without words. And some of that gets missed by his doctor and, doesn't really get picked up on well. And so, how do we actually attend to all of people's communication rather than just their words or lack of words? It also, of course, specifically in this, you have to look at, the skill of introducing and supporting an opioid taper, which I think is a skill a lot of physicians and nurse practitioners are learning these days. A broader, more comprehensive approach to pain management. How do we look beyond pharmaceuticals and talk about that in a way that is person-centered and is going to support their decision-making and their understanding of what their options are. Use of opioid agonist therapies for pain management and substance use disorders. So if somebody is, addicted or has been diagnosed with substance use disorder, or there's a concern about inappropriate use of opioids, can service providers actually talk about opioid agonist therapy its role as pain management, because it can be used for that purpose, but also its role in managing substance use disorder, if that indeed is part of the story. Provider safety when patients get angry. We heard a lot from service providers about their challenges in frontline care, and that included big emotions from patients and family members, right? Big anger, big sadness, and sometimes anger that escalated towards violence. And how do we support and train healthcare providers to respond to that in a way that focuses on their safety, while also being trauma informed, while also supporting patients, right? Another piece in Jim's situation, he had a surgery that actually triggered his chronic pain. And that is also not an uncommon experience. And so, how are we actually managing postoperative pain in ways that may prevent chronic pain developing, but also acknowledging chronic pain is possible and making sure people have a clear pathway to support if that becomes part of their experience. Learning about Canadian opioid guidelines, this story can be a really nice fit with that. And again, learning about community-based chronic pain resources, limited as they are at this point in Saskatchewan. And so, oops, this heading is wrong. Sorry about that. I was trying to work quickly when I put these together. So this is Dennis and Nurse Tracy's story. So the heading on the slide is incorrect, but Dennis is an Indigenous man from northern Saskatchewan who's in hospital in Saskatoon. We were sort of envisioning like RUH, right? And he's on IV antibiotics for a bone infection that originated from injection drug use. And he had to have surgery on his arm. So he's recovering from that. He's a long way from home. He's in pain. He's also worried about withdrawal while in hospital, right? That's going to be a challenge. And the story starts with Nurse Tracy coming in and asking about restarting his IV. And it's an interesting story because, of course, Dennis knows his body better than Nurse Tracy does. And he actually offers to start his own IV, which, of course, she politely declines. But it sort of illustrates these moments where we can truly connect with patients or people we support, whoever they are, in their own lived experience, their own expertise, and to not minimize that or dismiss it. Yes, Nurse Tracy knows how to start an IV, but in someone like Dennis, perhaps she isn't the best person, and actually exploring that and using it as a way to build rapport and connection. That, yeah, we can have a little chuckle about it. Maybe we can laugh a little bit. We can also acknowledge that, yes, Dennis, you probably do know your own veins better than Nurse Tracy does. And, that's, and Nurse Tracy does a lovely job in this story of actually acknowledging Dennis's struggles in this situation, that it's tough to even stay in hospital in this situation. And while in the story, we couldn't get into some of the deeper nuance that we talked about in the sort of story creation, but some of our backstory on Dennis, is just sort of wanting to leave, wanting to be anywhere but in this hospital bed right now, and being so tempted to just walk out, and having to work really hard to stay and get his treatment done. And so that being part of the backdrop here, how critical it is that we have healthcare providers who recognize how hard someone is working to stay in a bed, and that we might not even acknowledge that that's happening for them, and that it can make huge difference in people's story if we actually do acknowledge that just being here is hard. And yes, our intent is to help you get better, but you are having to go through some pretty intense stuff in order to sit here and allow us to do that. And so in this story, looking at, sort of learnings about concurrent management of acute pain and substance use disorder together. So looking at things like tolerance, withdrawal, and being able to manage those while in hospital, navigating difficult and, tense encounters with patients and colleagues. In this story, actually, Nurse Tracy, the tension is more significant when she calls the doctor on call to get some orders changed for Dennis, and gets sort of someone pretty snarky barking back at her on the other end of the phone. And the reality of Nurse Tracy's day is, she hasn't had a break. She hasn't been able to sit down. And then colleagues are also a source of distress. And so we felt it really important, because our healthcare providers said, the ones we interviewed said, that it was incredibly challenging sometimes to be a good healthcare provider when colleagues are sometimes a source of stress as much as patients and families are, and that it can be coming at you from every direction. We talk about harm reduction in this case, and looking at harm reduction in acute care settings and what does that mean, recognizing and managing symptoms of withdrawal, again, Indigenous wellness practices in acute care settings, unconscious bias, non-drug pain and stress management. So how can we help people manage what's happening without adding on additional drugs? Introducing substance use treatment or inquiring about substance use treatment, advocating for best practice care. How do we, try to maintain the integrity of our care in complex situations where we may be getting pressure from a variety of parties to not always provide best care. And then that therapeutic alliance, again, is really significant in this case. And so these three cases actually are very interesting in terms of their learning possibilities. Of course, for disciplines like nursing and medicine and other sort of health science disciplines, but also, have proven useful in social work classes. I've used elements of these stories in an addictions class I teach, Dennis's story in particular, but also looking at these as case examples for any discipline that is learning about how to build relationships when people are struggling and not, having their best moments, and, a lot's on the line. And so thinking of, communication courses, whenever we're teaching problem solving, those types of things would fit really well with any of these three stories. And so I mentioned earlier about SaskPain. Our stories are housed on SaskPain's website. And so the link on this slide goes to SaskPain's page where our stories live. They also have great information about pain, including non-pharmaceutical options to pain management, a little bit about what's available in Saskatchewan, and they do some social media work as well, sharing information about progress in pain management from across the country, and so are a really useful resource. They're a very small but mighty group who do a lot given the very minimal resources that they have. So the number one question we get is, can I use the stories? And our answer is always yes, please. And so we have a license on these stories that allows people to copy and distribute them without adapting, right? So if you want to ask us about collaborating or adapting, we've already had one group come to us and say, it probably took a lot of time to make these stories and cost a lot of money. And yes, it did. It was a labor-intensive process that did require significant funding in order to do that piece. And we know that not every organization has access to that sort of funding support, as well as just that, this was done by researchers and healthcare provider researchers, and the time is a big piece. And so one organization has asked if these stories could be adapted with different text. Change the story, keep the pictures. And so we're trying to navigate that right now and see if that's possible. We're very willing to share the artwork. Our designer has also been supportive of that, and sort of looking at how these could be used to tell different stories, and make that more accessible to organizations that don't have the resources. But yeah, reach out to us if you have questions about that. So I have some references, but I'm just going to stop my share and open it up to questions, conversation. And yeah, I'm just curious what people think and if you have any questions for me.
Hi guys. Can you guys
Hi.
hear me?
Yeah,
How are you doing?
good. How are you?
It's great to see you guys. I love the presentation. Thank you so much, Erin, for putting it on. Um, I was just wondering about the key learning opportunities that you have listed there, that you have for each story. When you're sharing your stories on the website, like with SaskPain or whoever, are those part of it, or is there like
Mm-mm.
discussion guides with that? I feel like that might
That's
be
been
something.
identified as one of our next pieces is
Yeah.
creating some we're trying to find funding for a video of a story as well. But then yes, we have used these in a couple different classroom settings where we have created some discussion questions and some small group activities, but those aren't available on the SaskPain website yet.
Hmm. I was
Mm-hmm.
just thinking about it for like a lot of like peers and like coworkers, just having just like even those like listed somewhere as part of the story, as
Mm-hmm.
part of the outcomes of part of like just like discussion prompts. Like I was just thinking
Yes.
that, but thank you so much.
Yeah, thank you. And
Great seeing you.
I'm just going to quickly share. I have one of the stories up right now, and I just want folks to see what the sort of last pages look like. So this is our first story about Teresa, and so these are how we framed our sort of what ifs. And so this could be used as a starting point for those discussion prompts, right? What if we explored the impacts of pain and discussed treatment options that are achievable to our patients, right? What if there's a clear pathway? So these are sort of aspirational statements, some of which are becoming reality. But yeah, you know, how do we do these things is the real conversation. Yeah.
All right. Noelle has her hand up, I think, there, Erin.
I
All right.
do. Erin, this is awesome. This is absolutely fantastic. I just have a ton of questions about the process and all of that stuff, but I won't even get into that today. Just again, kudos to you and the rest of the team.
Thanks.
This is just incredible. So just a couple of thoughts. I mean, my mind is going in all kinds of directions in terms of how I can use this in my courses. I oftentimes teach the undergraduate social work and healthcare settings. This fits in so many ways. I will say that as a therapist, I continue to work as a therapist in the community, not a lot, Tuesday afternoons and evenings. I have over the years worked with a number of folks who live with chronic pain. And, you know, I think certainly when I think about social work classes in particular, I think there's lots of opportunities to bring this material in addition to the addictions class, in addition
Mm-hmm.
to the healthcare settings class, right? And certainly I can say that, you know, the information that you've shared certainly resonates in terms of what I hear from folks that I'm working with as a therapist and their experiences. My question, though, is about the first story that you told in particular. I have people in my personal life, one who was in a really bad vehicular accident many years ago. Her life was changed irreparably, and she lives with chronic pain. Someone else in my life who was in a really bad motorcycle accident 3 years ago, life changed completely, lives with chronic pain. Um, Something that really, when we think about systems and the challenges with the healthcare system and healthcare providers and those relationships and all of those kinds of things, I'm curious if you heard from any of the folks that you talked with about the role of another system, that being SGI
Mm.
in this province, and
Yeah.
access to other opportunities and access to financial support and wage replacement and all of those kinds of things. Did that emerge at all? Because
Yeah.
that is something I hear over and over and
Yeah.
over again, specific to,
Mm-hmm.
you know, that as being a source of the chronic pain.
Yes, yes, absolutely. Yeah, we heard about people's challenges interacting with, insurance, workers' comp, SGI, especially when there's been an injury that's happened. And we weren't able to explore that in great depth because we were focused sort of on that substance use and chronic pain stigma piece. But there are multiple lines of data that speak to those exact issues and the challenges navigating those systems. But also, and where it showed up in sort of our story themes is healthcare providers also need to understand a little bit about those systems because they're having a profound impact on their patients. And, healthcare providers could be assisting a little bit with navigation, or at least affirming that, yes, these are very complex systems that are very challenging to interact with. And, just being a source of validation of that.
Well, and it's also interesting because, again, working with folks who are trying to navigate those systems, be that workers' comp or SGI in particular, in province, and oh my goodness, the ways that they describe being treated and that stigma. And then the other side of this, and this is the last thing I'll say because I don't want to monopolize everything here. I also, in my work as a therapist, provide counseling support through employee assistance programs, and have had the opportunity over the last number of years to provide counseling support to a lot of folks who work with SGI and are experiencing trauma in trying to provide guidance and support to folks who have been in these horrible accidents and really not feeling prepared in any way, shape, or form to do that. It's just a whole other avenue, Erin, that I think, oh, wow.
It's a world unto itself that I think does compound the stress of what people are already going through. And then, I think the worker perspective is another really fascinating piece to that, right? Thanks, Noelle. Okay, I'm just trying to see where the hands are up. I know I have another hand up. Oh, Jihad.
Yes, it's me. Hi.
Hi.
Thank you for this presentation and for this type of research. I like it. So I'm a patient with a chronic pain. I am also a researcher and a pharmacist. And recently my husband had a car collision. And I also experienced some of these struggles when I was pregnant with my second. She's 2 years now. So I think the three, all of these stories have really touched me, and I've experienced most of these situations. And so I appreciate your effort, the whole group effort for studying such cases. And I agree with all of what have been said, that it's really happening and it's really hard and needs many or much efforts. The question is, the outcomes of this research, how would or can we apply this to be a practical things for the doctors and the patient? Is there any chance to collaborate with government or politicians or any kind of collaboration? Because this is a hard work and it really highlight what we are facing as patients and as also doctors or healthcare providers. So we need this to start to be applied. Is there any a plan for?
Yeah, so we're working on that. So Dr. Susan Tupper actually is the pain strategy lead in the Health Authority, Saskatchewan Health Authority. So this work has been dovetailed into the pain strategy work in the Health Authority. And we are also connecting out into education within healthcare systems. So nurse education days, for example, and trying to get this out there. The other piece we're looking at, of course, is post-secondary presentations and getting into classrooms and catching folks before they're out practicing independently. The other piece that we want to do is look at how patients or people living with pain would want to use the stories. And so we've talked about things like even having printed copies sitting in waiting rooms. And, how would that influence the experience of care for someone, waiting to see a physician, something to do with their pain or not, and seeing this in the space and interacting with a story before they go in. And so there are some subsequent research questions we have, but also really a desire to get this in the hands of, the primary target here is healthcare providers, and challenging some of the attitudes, the stereotypes, the stigma, through education. And so we didn't have money in this grant to print anything. And so the question is printed ideal? Are there other formats that would work well? We've also looked at several environments in hospitals across Saskatchewan have now got screens in patient-facing areas, where you can put content on. And
Yeah.
we're having some conversations about, can we get versions of these comics maybe when we have a video, or maybe just as different slides go by that show people the
Yeah, this is
story.
a good and easy idea too.
Yeah,
I have another like thing. As you said, the main targeted people is the health provider. So I see and I encourage what you have said, that you started to teach like healthcare students, but I think to make it faster, we need the current healthcare providers to be educated. So maybe, something like this, meetings with the current people who are working on the maybe the emergency, or the doctors who are special, like the rheumatologist, or who are mainly work with the people, with the patient in pain.
Mhm.
So I'm not sure if this is like available or could be done. Sorry, I just need this to be like as fast as
Yeah,
soon as possible to be
I get
delivered,
that. Yeah.
because it's hard to live like with this for many years until the other generation come and grow up.
Yeah,
Yeah. So
yeah. And we also want new graduates and students of different healthcare disciplines to be learning in systems that are not perpetuating stigma, right? And so, we hear that from students often. We teach them an ideal in the classroom, they go out into the real world, and those ideals don't really fly, right? And so, how do we make sure that, yes, people who are doing this work now are learning, as well as the next generation of
yeah,
healthcare providers? Yeah. And
the 0 to 10, it's really triggered me. So my daughter had two
yeah.
surgeries, and we originally, like, we're not Canadian. We used to live in Egypt, so it's was totally different for us to experience this. But when we got confused, we started to think, but most probably they knew what they are doing, so most
Mhm.
probably this is the best way. And then we started to doubt ourselves. So for me to hear this today, it's like, oh, that's okay. There are other people who think same as we think.
Yeah.
So
Yeah.
yeah,
Yeah.
please
And
find a
that's,
way to reach for the current healthcare providers.
thank you. We
Thank
have
you.
actually, we're in the process of scheduling a couple grand rounds presentations, trying to target physicians in particular, who work in particular practice areas. One gap that was really clearly identified is that general practitioners or family physicians often don't understand pain. They may not have been educated in it much at all, when they were trained. And so, how do we make that enticing to family physicians, for example, and reach them? So we're really trying to look at that. And yeah, I feel you. I came into this work because I've lived with pain for over 40 years, and have experienced the messiness of the healthcare system when it comes to this issue. And it certainly, I think, brought a lot of depth to the research, because we've included several, not just me, people, a variety of people living with pain have brought their perspectives to this work. So yeah, thank
Yeah,
you so
thank you.
much. Hmm.
Any last question for Erin? Okay, hearing none, Erin, thank you so much. That was fantastic and really exciting to see where this goes next. And yeah, thank you for sharing your project and please come back and let us know what
Happy
happens
to.
next. Yeah,
Yes,
that would be wonderful.
absolutely. Yes.
Yeah. And thank you everyone for attending today. We will have another Lunch and Learn in November, so stay tuned for those details. And we appreciate everyone making the time to come out. And thanks again to Erin. Have a good day, everyone.
See you.
Bye.
Bye.